accessible for all. So that would have been made it even more clear. But this is a slogan with which we're going to work with. And on this World Asthma Day, you're hoping that we'll have a fruitful discussion. And I'm also eager for your comments because we have some very senior pulmonologists also having joined us. Pipin is there, Dr. Rajana is there, Dr. Jajamani. So all members of KGMOA who are also members of APCCM. So glad that everyone is there with us today. So to move on, the plan for today is that I'll be discussing briefly on the burden of asthma to highlight what we actually need to do. Then move on a bit to the diagnosis and treatment of asthma. The new guidelines for asthma, the GINA guidelines, were released today. So, it was a bit of reading for me today afternoon to evening. I was reading what is new. It's a bit confusing always because only that subtle minor changes would be there from 2024 to 2025 guidelines. So, you have to sit through the guideline, read through it and find out what is actually changed. Or you might even miss the subtle changes. They do give a chapter telling you what is new and all that, but often, it gets a bit confused. Anyway, I've gone through the new guidelines. We had 2 sessions in the morning today, but there I could not go through the new guidelines because I was busy with ward work and all. But for this session, I could go with the guidelines, and some of the slides I put in are with the latest guidelines which are released today internationally. And then we'll briefly again discuss on what is our role of KGMOA, role of all government doctors, you and me together, on how we can actually approach asthma at primary care level, what we have done in Kerala, and just briefly, not too much on that. So moving on to the disease burden. So today morning, we had a discussion in the community medicine department to discuss the burden and the epidemiology. So some of the slides that I prepared for that, I felt that I should be sharing with you. So this is coming from a source called the Global Burden of Disease, so GBD, which actually gives you estimates of almost all diseases. And the advantage of GBD is that it even gives you state-wise estimates. So these are estimates for India that I'm discussing. So if you look at the change in disease burden from mortality from 1990 to 2021, many causes of mortality have gone down the list. So if you take, for example, measles, it was top 10 cause of mortality at number 8 in 1990, but it has now come down to even beyond the top 100 causes. But certain causes of mortality are on the increase, which include ischemic heart disease, COPD, stroke, diabetes, chronic kidney disease, and asthma. So, asthma is a cause of death which is actually increasing. So, that is the significance of asthma and asthma mortality. If I could take it a bit backwards and go to the 2019 statistics. So, I had prepared this for even a presentation earlier. So there, when you look at it in, to 1990, if you look at the top 10 causes of mortality, the respiratory causes were pneumonia, COPD, and TB. Whereas now TB has gone out of the top 10 in 2019 itself, 2021 also, it's not in the top 10 anymore. But COPD, pneumonia, and lung cancer are in the top 10 in the world. So what I'm showing right now on the left side is from the world statistics. But when you move to India, you see that, lung cancer is still, it's on the increase. It's a major cause of death, but still it has not come to that level as it is globally. But you can see that asthma has now creeped in. In the previous global data that I was showing you for mortality, asthma was not even there in the list. It is much lower down. But in our Indian, static cause of death, which is a surprise because this is actually indicating that the mortality, proportional mortality per lakh population in India and some of the surrounding countries, for example, you can see Myanmar, you can see Nepal, Sri Lanka, so Afghanistan. So all these countries, the mortality due to asthma is much higher as compared to, say, the Western countries, European countries, US and all that. Maybe some African countries, particularly South Africa is the other area, and Indonesia is the other area where the mortality due to asthma is high. Again, when you classify countries based on low, high income, upper middle income, lower middle income, and low income, you can see the last set of bars here on the right side represent asthma. So if you look at the burden of disease is more or less similar between high income, high middle income, and low middle income. But when it comes to mortality, highest proportion of mortality, almost 80% of the mortality comes from the lower middle income countries, which includes India. So we have a disproportionate share of the mortality due to asthma. And if you look at the actual rates of mortality per lakh population, you can see that India comes in the top 12 or so causes. And the other countries in the list are very small countries. Some of these countries, I didn't even know the name of the country until I downloaded this data. So the major countries here are Myanmar, Nepal, and India. So we have a mortality of 14.6 per lakh population when compared to the global average of 5.5. When you take the whole world as a whole, it's only 1/3 of the mortality we have in India. And when you take countries like US and all, our mortality is almost 12, 13 times the mortality that those countries have. So this is what Dr. Judo was saying earlier. So that this is a preventable mortality, not just that the mortality is there. Now, some of the mortality due to stroke or, COPD, for example, cannot be reduced even if you give a lot of treatment and all. So you try to prevent it from occurring, but once it has occurred, there's not much you can do. But with asthma, mortality can be prevented, and India has such a high mortality that if we manage our asthma properly, we can significantly reduce the deaths that occur due to asthma. So significant number of people die every year in India due to asthma, and those numbers can be reduced. And Dr. Judo and I and most of the pulmonologists here would believe that nobody should actually die of asthma. We should try to prevent every asthma death. Now, GBD also gives you state-wise estimates. So if you look at it, asthma is more prevalent in the northern states of India, particularly Rajasthan. And if you look at the morbidity due to asthma in terms of disability adjusted life years, you can see the highest is in Uttarakhand, and again UP and Rajasthan suffer a lot. And if you take mortality, again the highest in Uttarakhand and quite high in Rajasthan and Uttar Pradesh and in Himachal Pradesh. So if you look at the mortality in Kerala, the estimates are 8.2 deaths per lakh population, which is quite high. It's not a small number with our population. Large number of people would be dying of asthma in Kerala. But then the mortality in Uttarakhand is almost, 3 times plus of that number that we have in Kerala. So in terms of India, Kerala, of course, as in other diseases, is doing better. But still, we also do have a substantial mortality in Kerala as well. So this is in that context that you want to reduce mortality. And whenever mortality due to asthma in India is discussed, generally the discussion goes that our management of asthma, particularly the access to inhaled corticosteroid or the willingness to take inhaled corticosteroid is low in India. And because of that, mortality remains high. So that is the way the world sees our asthma burden and asthma problem. So that brings us to the question that we should be diagnosing asthma well and managing asthma well, as Dr. Judo said earlier. So how do we actually do that? So, I'm not a big man for definitions, but this is one definition which I always love because it covers a lot of things. Asthma and COPD definition covers a lot of about the disease. And by just reading the definition, you can actually know everything about the disease. So the definition goes that it's a heterogeneous disease characterized by chronic airway inflammation, defined by history of respiratory symptoms, which include wheeze, chest tightness, shortness of breath, and cough, that vary over time and in intensity, and together with variable expiratory airflow, and the airflow limitation later may become persistent. Here, the key points to take out of this is that chronic airway inflammation is the most important, set of words in this particular definition. So the difference in the understanding of asthma, like Dr. Judo said, this organization called GINA came in somewhere in the 1990s. That was the time when I was doing my PG. And in fact, the first GINA meeting in India, I could attend with some of the world luminaries actually having attended. And we got a free GINA book on which we got autographed by some of the leading asthma experts in the world. So in that particular meeting, the major difference that we, learned about asthma is that in asthma, the major problem is inflammation, and the inflammation is chronic. So even when the patient is asymptomatic, when the patient is totally normal from outside, the inflammation is actually continuing inside, which you can pick up by either doing a bronchoscopy and taking a biopsy or doing induced sputum and looking for inflammatory cells in the sputum. And since the inflammation is continuing and the inflammation leads to the hyperresponsiveness that occurs in asthma, you have to control the inflammation if you want to control asthma and if you want to make the patient okay. And it's a chronic inflammation, so a short-term treatment would not work. So you need long-term anti-inflammatory medication. And obviously, the best medication which works in a eosinophilic inflammation like asthma is corticosteroid. Because our problem then would be, how can you give long-term corticosteroid to a patient who is not that sick? I mean, certain conditions like interstitial lung disease, which responds to steroids, the mortality risk and the suffering is so much that you do give long-term oral corticosteroid. But in this particular disease, do you need to give oral long-term steroid? You cannot give that. And so the solution came in terms of inhaled medication. So the whole idea of inhaled medication is to reduce the side effects so that, you can give the anti-inflammatory drug, the steroids, directly to the airways and tackle the disease without causing side effects. So that is the whole crux of the thing. So if we just learn from today's presentation that if it is asthma, you have to give long-term or at least medium-term inhaled corticosteroid, then the job is done well. Of course, for the diagnosis, the major thing that I put here is variable expiratory airflow. The previous definition last year had the term variable expiratory airflow limitation. They took the limitation out because obstruction may not be present in asthma, but the variability is something that you have to demonstrate. And if you don't give proper anti-inflammatory medication, the inflammation will lead to airway remodeling. So the fibrosis and all will occur, and then the airway will become permanently obstructed like a COPD patient. And there your medication later may not work. So your whole idea is to ensure that you tackle the inflammation well in time, and this persistent airflow limitation, which is similar to COPD, does not occur in your asthma patients. So that the definition itself covers the whole lot about disease and also tells us how to manage the disease, diagnose and treat the disease. So in the diagnosis of asthma, history is very important. So if you see respiratory physician, you'll see that when a patient with asthma comes, they spend a lot of time in history. And the history is extremely important in terms of looking at the symptoms, the nature of the symptoms. I'll come to that later. The presence of various triggers, which are, certain exposures or something like that, which actually increase the asthma symptoms in your patients. And also the family history. The family history is the extended family history. You don't just ask mother, father. You have to ask about mother, father, grandfather, grandmother, paternal, maternal, ask for brothers, sisters, cousins, ask for children, grandchildren. So you ask the extended family history in terms of you ask for asthma in the family, you ask for atopy in the family, you ask for, any kind of allergy in the family. So that you also ask in the patient in terms of, previous history of atopy or allergic rhinitis. So this history becomes extremely important. And then, of course, you have to do the spirometry and demonstrate variable airflow, expiratory airflow. Now, the typical symptoms that you're looking for are wheeze, shortness of breath, chest tightness, and or cough. So, the GINA itself says that this descriptions or the names used for this may actually vary from region to region. So people, you have various terminology. And, when you go to certain parts of Kerala, if you're not used to the local slang, you might even miss a diagnosis because you don't pick up what they're trying to tell you. So that is also important in learning how these symptoms are mentioned in the local language in that local area. So these symptoms, wheeze, shortness of breath, chest tightness, and or cough, should be variable, should vary over time and vary in intensity. It would be worse at night or on awakening, early morning symptoms. Symptoms are triggered by exercise, laughter, strong emotions, exposure to allergens, exposure to cold air. So all those things, there are certain triggers which actually increase the symptoms. These worsen after end exercise. So during the exercise, the person may be able to do exercise well or play a game well, but then at the end of it, they suddenly have a wheeze. So that is also typical. And they often worsen with viral infection. So when you use the terminology in English, they, Sahipന്റെ ഭാഷയിൽ they say that folds which go to the chest. So you start with upper respiratory infection, but they end up with wheezing and, respiratory, lower respiratory symptoms is often a typical symptom of asthma. So all these things should be considered whenever you are thinking about diagnosis of asthma. Of course, there are certain other symptoms which may lead you to think that this may not be asthma. Let me think of some other diagnoses. And these include isolated cough without any other respiratory symptom. Mind you, this can happen in a form of asthma called cough variant asthma. So we should not just write off such patients, but generally, you have to think of other alternative diagnoses. Right? Chronic sputum production is a feature of bronchiectasis, or you have to think of other conditions like tuberculosis and all that. But then again, this can also occur in asthma when a patient with asthma has a ABPA or a bronchiectasis together with the asthma. This can happen. So, I mean, each of these things, you have to think of alternate diagnosis. Also, in the back of your mind, you should keep it in mind that this could actually be asthma as well. So, shortness of breath, generally associated with dizziness, lightheadedness, or peripheral tingling, is a person who's hyperventilating and leading on to respiratory alkalosis. So you have to, maybe control that. Maybe the treatment may not be the treatment for asthma. Chest pain may occur with cardiac causes and many other causes, pleural effusion, pneumothorax, and all that. So whenever you have chest pain, it's not a feature of asthma. Evaluate for other alternate diagnosis. Exercise-induced dyspnea may happen in asthma, like we mentioned in the previous slide. But then when you have noisy inspiration, stridor, this may be due to, inducible vocal cord dysfunction. So you have various differential diagnoses, which you have to keep in mind. The symptoms are overlapping between these, and you have to always not jump to a diagnosis. So you have upper airway cough syndrome, inducible laryngeal obstruction, vocal cord dysfunction, which is more or less related. Then you have a hyperventilation as in a hysterical patient, bronchiectasis, cystic fibrosis, heart failure, COPD, foreign body aspiration, medication-induced cough, parenchymal lung disease like interstitial lung disease, pulmonary embolism, central airway obstruction, tuberculosis, and pertussis. So all these things should be kept in mind. I myself have gone wrong in, often in a patient with a old CA breast, I diagnosed asthma. It was a close family friend, and later it turned out to be my mediastinal nodes in that particular patient. So, if you don't think of those things, you actually might miss the diagnosis. So keep all these things in mind, and then you actually work with that. When you're trying to diagnose asthma, the new GINA guidelines go with this diagnostic algorithm, not very clearly visible. Let me try to break this into two for you. So the upper half of the algorithm talks of typical symptoms. We already discussed what are the typical symptoms. And then you take a detailed history, look at the family history, look at the triggers, look at past history in terms of allergic rhinitis and all that. And then you look at whether these support the diagnosis of asthma. And if so, you actually go ahead with a spirometry. And GINA now recognizes that countries like India may struggle to have a spirometry done. So they do suggest a peak flow measurement as an alternative. Now, if these things are not there, like we mentioned, if the symptoms are not typical, you work up the patient for alternate diagnosis also. But if the alternate diagnosis does not come positive, you come back again and then you go to a spirometry to look for whether this is asthma. Often, quite often, patients come to us for the first time with an exacerbation. So they do not come when they are having less symptoms. They come when they have exacerbation. And in such patients, you have to first treat the exacerbation. And maybe once you treat the exacerbation with systemic steroid, particularly oral steroid, then you may go with a medium dose inhaled corticosteroid in such people. And some patients, particularly in today's era, by the time they come to us, particularly to the medical colleges and all, they are already on treatment. So mostly, some doctor would have started the inhaled corticosteroid, which complicates the diagnosis because the patient is already on the right treatment. There are very detailed guidances in the current document and in the previous documents on how to deal with such patients who are already started on an inhaled corticosteroid. It involves stopping the inhaled corticosteroid or looking at whether symptoms increase or stopping and doing a spirometry and all that. It's a bit detailed, and I'll not go into the details in this particular presentation. Once you've done a spirometry, as you've seen in this at the bottom of it, once a spirometry is done, what you actually have is, does the patient have a variable airflow, which I'll tell you what it is later. So if the variable airflow is there, then you confirm the diagnosis of asthma and you start the patient on a inhaled corticosteroid containing treatment. What the treatment is, that will come later. If the variable airflow is not demonstrated, there are two things. Either you can actually, wait till the patient's symptoms come and repeat it after a few, weeks or so. So that circle may continue again and again, trying to establish diagnosis of asthma. Or you might consider biomarkers. Mainly, they look at blood eosinophils and FeNO, and these may suggest that maybe it's asthma. And if other diagnoses are unlikely, you start with an empirical treatment with inhaled corticosteroid. In such people who are on empiric treatment, you will review the response in 1 to 3 months with either a spirometry or a peak flow. And then if the symptoms have reduced and the patient is doing well, you may actually continue with the inhaled corticosteroid. So this is in brief on how you actually approach the patient towards a diagnosis and management in asthma. Now, everywhere in the slide, as you saw, spirometry is a very key test in all these patients. And spirometry, a typical spirometry in asthma patient looks like this. So as we had discussed earlier also in COPD days, so spirometry actually has a pre-bronchodilator and post-bronchodilator. Both have to be done in our Schwarz and all. We have written only a pre-bronchodilator spirometry. Ideally, we should be doing a pre and post-bronchodilator spirometry. And you look at what happened when you give a bronchodilator also. So this particular patient, you can see the FEV1 by FVC is 61%, which is 70% is the cutoff. So it's less than 70%. It indicates that this patient, before you gave the nebulization, had an obstruction. But after the nebulization was given, this obstruction was actually relieved. It went to 71%. So the patient no longer has an obstruction. Now, if you look at the FEV1, why did the obstruction disappear? Because the FEV1 actually increased. So the FEV1 in this patient was 1.98 liters or 1,980 ml, and it increased to 2,380 ml. So the increase is 400 ml, and the percentage increase is 20%. So this patient's FEV1 increased by 400 ml and 20%. And you consider that this is reversible or that bronchodilator reversibility is present if the FEV1 or the FVC actually increased by 20% and 200 ml. Both should be there. Minimum of 12% and 200 ml. So both these things are there. Then you consider that this is reversible. So the guideline very clearly tells you how you actually consider reversibility in your asthma patients. So either it can be due to a response to a bronchodilator, usually a nebulized salbutamol, and then when you repeat, either the FEV1 or FVC increases by 200 ml and 12%, like I mentioned earlier. The confidence for diagnosis of asthma is more if that increases 400 ml or 15%. So our particular patient that we discussed in the previous slide had an increase of 400 ml and 20%. So that patient, you can have more confidence that that patient has asthma. Now, if spirometry is not available, as usual in many of our hospitals, then you could do a peak flow measurement. And if the peak flow increases by 20% after bronchodilator, that also can be considered as a surrogate for bronchodilator reversibility. You could also tell your patient to actually do a day-to-day monitoring of peak flow. This is ideally done in all patients. So, in the Western countries, every patient in whom you diagnose asthma has given asthma chart. And that chart, morning and evening, he or she has to record the peak flow recording. I have done that with well-to-do patients as well in India. And the peak flow meter is not very costly. It just costs around 300 rupees. It's a very good tool, but our patients are not so used to self-monitoring, But there are good patients in India, who actually would daily monitor their blood sugar, may daily monitor, self-monitor their BP. So if you have a patient like that, it's a good idea to actually monitor peak flow. And if the peak flow, it's varying from morning, evening, the diurnal variability is more than 10% in adults or more than 13% in children. That is also in favor of asthma. The other thing you do is, like you said, the empirical treatment we discussed in the previous slide. So if you give an empiric treatment with inhaled corticosteroid, and then after 4 weeks, when you assess the spirometry again, if the peak flow, if the FEV1 or FVC has actually increased by 200 ml and 12%, again, you consider asthma, or a peak flow has increased by 20%. Between visits also, after 3 months or between 1 month and all, when they come, if there is a variability in their, lung function, as discussed earlier, such people also are in favor of asthma. Of course, one of the major tests, which is more of a research test, even our medical colleagues don't do that much, is a bronchial provocation test. It's a risky test as well, because you're trying to provoke a reduction in FEV1 in your patient. And some patients can have a severe exacerbation when you do the test. So I'm not going to details of the test, but that is also one of the tests which is recommended for your asthma patients. Remember that, because sometimes people go ahead and try to do a bronchial provocation test. That is a test with risk. So it's not a totally safe test. We discuss a lot of differential diagnosis, but at the end of the day, the two major diseases that you have to differentiate is COPD and asthma. More or less similar diseases, more or less similar symptoms. The major difference is, of course, that the chronic airway inflammation in asthma is eosinophilic and it responds very well to corticosteroids, whereas the inflammation in COPD is more of a neutrophilic inflammation, doesn't respond very well to steroids, and often doesn't respond at all to steroids. And the airflow limitation, which is in asthma, is variable, whereas in COPD it is persistent, often progressive. So, that is a major difference. So you have to differentiate between asthma and COPD. And a kind of syndromic differentiation can be done. You can look at the age of onset, which will be lower in asthma and higher in COPD. COPD is often diagnosed only after the age of 35 or 40. So if you diagnose a COPD in a patient who's 20-year-old, you are more likely to be wrong. But you should remember this is age of onset. So your asthma patient may be coming to you at the age of 50 or so, but then you have to take a proper history to find out when the symptoms started. So often their allergic rhinitis would have started in young age. Their dyspnea might have started later, but then you have to consider that as well. Associated atopy usually is not present in COPD. It can be present, but usually not present. But allergic rhinitis or a skin atopy would be present in that particular patient or in the family of the patient. The symptoms in asthma are typically episodic or variable. And even over a period of time, it doesn't increase that much. It's not progressive. Whereas in COPD, it is exertional dyspnea, which occurs on exercise or moving around. Persistent symptoms are there, and the symptoms are progressive over the years. COPD, generally, you have to elicit a history of some kind of exposure, which could be cigarette smoke or biomass fuel or work space smoke or other exposures. So those things have to be there in COPD, but usually not present in asthma. But of course, your asthmatic can be a smoker as well. So that you have to keep in mind. And finally, at the end of the day, spirometry, as I said earlier, in a COPD patient, the post-bronchodilator, FEV1 by FVC, which actually became normal in the case that we discussed, will not become normal. It has to remain always below 670%. Only then you can diagnose COPD, whereas in asthma, you can demonstrate the reversibility or increase in FEV1, FVC, or peak flow. The major reason why you want to differentiate is that, one, the prognosis is different. So as a doctor, when the patient comes to you, you want to tell the patient what to expect from your treatment. So if it is asthma, I'm very happy. I tell the patient that I can make you near normal. Whereas with a COPD, I'm very guarded with my prognosis because I know that the patient's symptoms will increase. So ആദ്യമേ ഒരു മുൻകൂർ ജാമ്യം എടുത്ത് ഇത്രയും കത്തിപ്പോയി റീകൂപ്പ് ചെയ്യാൻ പറ്റില്ല എന്നൊക്കെ പറയും. Because otherwise, after 2 or 3 months, the patient will come and complain to you, doctor പറഞ്ഞ പോലെ മരുന്നെല്ലാം എടുത്തു, I'm still having symptoms. So that has to be anticipated. So that prognosis, and more important, that is a treatment. So any treatment for asthma without an inhaled corticosteroid is an incomplete treatment. So whatever treatment you give for asthma has to include an inhaled corticosteroid. Whereas in COPD, you are generally not supposed to give inhaled corticosteroid unless, of course, there is an overlap between COPD and asthma, or if the patient has certain things which actually, in the guidelines suggest that a steroid may be beneficial. Your mainstay of treatment in COPD is bronchodilators. So this major difference has to be kept in mind when you're managing, because these are more or less similar diseases. And often what happens is people just club the two together and give them the same treatment, which is a wrong thing to do. It's dangerous for your patients. Having said that, having emphasized on the importance of spirometry, what is the real life scenario? The real life scenario is even my community of pulmonologists, when they treat COPD and asthma, only about 2/3 of the patients undergo a spirometry. Even among pulmonologists, 1/3 of the patients are treated without a spirometry because of obvious reasons. There are spirometry is often not available in many places. Access to spirometry is difficult. It can be costly if done in private and all. On the other hand, when you take physicians and general practitioners, only about 15% of their patients actually undergo spirometry. This is a sorry state of affairs. The international guidelines also recognize the fact that, in many countries like ours, this is the reality and many of the patients do not have access to spirometry. That is why they brought in the peak flow, and that is why in Schwarz program, we brought in the mini spirometer and all that. So, those local adaptations are needed, and we have to keep these things in mind that often a patient may not have access to spirometry. Now, once you're diagnosed asthma, you start assessing the patient. The first step is to assess the control that the patient has, the control of asthma, which is done by, about 4 simple questions. Do you have daytime symptoms? And if you have daytime symptoms, how many times a week? So up to 2 times a week is considered okay. It's acceptable or whatever term you use. But any nighttime symptom during the week is considered as abnormal. So no nighttime symptom should be there. If you are using a reliever medication, using it up to 2 times a week is considered okay. So if you use more than 2 times, that is considered to be a sign of loss of control. But any limitation of activity is considered as a serious thing. So suppose the patient has daytime symptoms 3 times a week and has nighttime awakening once a week and has been using the whatever reliever the patient is using about 4 times a week, and then is limited in activity also. And if all 4 are possible, then that becomes uncontrolled, because any 3 or 4 of these being positive makes the patient into an uncontrolled asthma. Whereas if all these questions your answer the patient gives is no, no daytime symptoms, no nighttime symptoms, no use of, I don't have to use a reliever medication, I have no limitation in my day-to-day activities, then none of them are present, you consider this patient as a well-controlled asthma. And somewhere in between, if 2 or 3 of them are present, you say it's a partly controlled asthma. So your whole idea of management is based on this. You have to classify your patient into uncontrolled, and repeatedly this evaluation happens. And each time you evaluate, you ask for the last 4 weeks, what actually happened to the patient. So each time patient comes, you ask for control. If the patient has uncontrolled asthma, you give medication and try to move the patient to partially controlled or well-controlled asthma. If the patient has well-controlled asthma, then you try to step down the dosage of the medication and bring the medication to the lowest possible dose at which you can actually maintain the well-controlled asthma. So it's a controlled circle, and based on that, you actually manage your patients. While you evaluate in the beginning itself, you also evaluate for risk factors for exacerbation. Any patient with severely uncontrolled symptoms is a risk factor of exacerbation. We have to understand that exacerbations can result in mortality, so you have to always be guarded on that. The other risk factors for exacerbation include the overuse of short-acting beta agonists, inadequate steroid use, comorbidity like obesity, rhinosinusitis, GERD, food allergy, and all, which have to be managed. Exposures have to be prevented, including smoking, allergen exposure, and air pollution. Psychosocial factors have to be addressed, and low lung function should be considered as a risk factor. High blood eosinophils or FeNO should be considered, and the previous history of intubation, ICU care, or severe exacerbation is also a risk factor of exacerbation. There are other risk factors for persistent airflow limitation occurring in your patient also, which include low birth weight, preterm birth, and all that. Certain medications and also certain exposures can put the patient at risk of permanent airflow limitation. Asthma management is not all pharmacotherapy. We'll be discussing pharmacotherapy in the next few slides, but we have to remember that even there are other things other than drugs. So patient education and communication is considered very important. There's a whole chapter on that in the guideline document on what all to tell, what not to tell, and how to tell all those things. I'll not go into details of that. And the other non-pharmacological management includes smoking cessation, physical activity. Physical activity is a double-edged sword. So if your patient's asthma is not controlled, physical activity can actually increase the asthma symptoms, either during exercise or after exercise. On the other hand, if the asthma is well controlled, physical activity actually improves the asthma. So you have to tell your patients that, so that they have to do physical activity, but don't do it while they have uncontrolled asthma. Many of our patients try to control asthma by doing yoga. Yoga is good for asthma, but then you have to do it after you control your asthma, not before you control as a treatment for asthma. Allergen avoidance is extremely important. Generally, you're looking at indoor and occupational exposure. Indoor include funguses and all that in your households, various dust and dust mite. Pets, the current guideline says pet exposure is not, if you remove pets, it doesn't do much good. But then, we have had good experience that whenever we have certain patients who have uncontrolled asthma, the pet may be the reason, and at least such people, they benefit because the pet is removed, which is a very difficult task because they love their pet. Healthy diet, which is very important. You should not restrict diet unnecessarily unless the patient has a specific allergy. And, certain things like beliefs, false beliefs that patient have. Those are all false beliefs. I don't know how well you can convince your patients on that, but definitely you have to give a healthy diet to your patient. Weight reduction, very important. Breathing exercise is again quite useful. avoiding air pollution and extreme climate changes. Extreme cold and extreme heat can actually increase the asthma. And you have to address the psychosocial factors also. These are also very important in an asthma patient. Since I'm using certain terminology, I'll just go ahead explaining what terminology, because we pulmonologists keep saying SABA, LAMA, SAMA, SA, LAMA, and ICS, just to clarify what actually it means. So SABA is short-acting beta agonist. The prototype is salbutamol, which we use regularly. LABA is long-acting beta agonist. The prototype, there are two sets of drugs. One set of drug, particularly formoterol, is a drug which is long-acting, also has a rapid onset of action. And that is very important because in the therapy that we are going to mention in the next slide, this rapid onset of action is very important. So most of the therapies now recommend formoterol over other long-acting beta agonists. Earlier, we used to use a lot of salmeterol, but because it is slow onset of action, it will take time. And if you want to use the same medication as a reliever, this will actually not work. So you have slow onset LABA and a rapid onset LABA, and the rapid onset LABA, which is formoterol, is preferred. Then you have the muscarinic antagonists, which actually include short-acting. The prototype is cipratropium. We call it SAMA. And the long-acting, which the prototype is tiotropium, we call it LAMA. So these are the terminology we commonly use. And then you have inhaled corticosteroid, which you call ICS, and various types of inhaled corticosteroid. And each of them you classify further into low dose, medium dose, and high dose. It's important to know this because, for example, a fluticasone salmeterol combination that we use, often we give them a 250 microgram MDI, 2 puffs BD. If you're doing that, the patient has actually gone into a high dose, more than 500 of fluticasone becomes high dose. And if you're giving a high dose, then you have to be careful in terms of side effects. So inhaled corticosteroid generally given to reduce side effect of steroid to patients. But if you're persistently giving high dose inhaled corticosteroid to your patient, such patients can have steroid side effects with those high dose inhaled. So always try to keep the dosage of steroids to the lowest possible to which patient responds. Of course, some patients do need high dose inhaled corticosteroid and they have to be given high dose inhaled corticosteroid. But as and when possible, try to step down dose as per guidelines to bring it to either medium dose or low dose inhaled corticosteroid. The other clarification which I want to give is that you use these terminologies called reliever medication and controller medication. This is a traditional usage. Reliever medication are generally the medications which are given when the patient has sudden symptoms and you want relief. You just give it when symptomatic. These are SOS medication. The prototype used to be salbutamol. And controller medication are medications which have to be taken regularly to prevent asthma attacks and asthma, pathology from increasing in the patient's airways. And these have to be used regularly. Maintenance therapy and controller therapy earlier used to be synonymous with that same meaning. But controller is mainly to prevent further symptoms or exacerbations. Whereas now, the medication we are using is almost the same medication is used as reliever and controller. So the use of controller terminology is slowly coming down and they are using the terminology maintenance therapy, which is, you have to continue using, and the same medication can be used as a reliever also. Now, in the guidelines, you will see the usage of the terminology called MART, which is maintenance and reliever therapy. It initially started as SMART. So it was single maintenance and reliever therapy. Now it is called MART, maintenance and reliever therapy, which actually means that the same inhaler can be used as your maintenance inhaler regularly to prevent asthma. So same thing can also be used as a reliever as and when the patient requires. So that we'll come to in the next slide. And then you use the term AAR, which is anti-inflammatory reliever. So the reliever medication has an anti-inflammatory drug also, which actually makes it better for asthma. So when you look at the pharmacotherapy of asthma, there are two tracks of treatment. And the track 1 is preferred over track 2 because that leads to better outcomes in patients. So in the track 1, the major thing is that your formoterol containing inhaler. So in the Western countries, you have budesonide formoterol and you have beclomethasone formoterol. Whereas in our country, we do have other combinations like, fluticasone formoterol and all other combinations also there. The key thing is that your inhaled corticosteroid LABA combination, the LABA has to be formoterol. Only then you can give the MART therapy. So in the MART therapy, you have step 1, step 2, step 3, step 4, step 5. I'll come to this in the next slide. So if your patient is, probably if the patient is in step 4, which is medium dose inhaled corticosteroid, the dosage we saw in the previous slide, and then after 3 months, the patient is having well-controlled asthma for the last 3 months, you can go back to step 3. Or if your patient, you started on step 1, which is a SOS as required inhaled corticosteroid formoterol combination, but the patient still has symptoms every now and then and has only a partially controlled asthma, you will go up to step 3. So based on the symptom cycle, so this is assess, adjust, and review. So based on that, you either step up or step down based on the symptom control that we actually discussed in the previous slide. The alternate medication also here, salbutamol can be used as a reliever, but generally what they recommend is if you're using salbutamol as a reliever, use a steroid salbutamol combination so that the patient gets the benefit of anti-inflammatory drug also. So that becomes a reliever and controller medication together, so which is called the AIR, the anti-inflammatory reliever medication. So where do we start when the patient first comes to you? So when you first comes to you, if the patient has only symptoms 1 to 2 days a week or lesser, then he's in step 1. Or if he is having 3 to 5 days a week with normal or only near normal lung function, then he's in step 2. There, you need to give only low dose inhaled corticosteroid with formoterol. For example, it could be a budesonide formoterol, 100 microgram, 2 puffs BD as an inhaler, meter dose inhaler. Then it probably remains in the low dose level, and then that treatment SOS as and when the patient requires. If the symptoms are 4 or 5 days a week or more, and the patient is awake, having nighttime awakening with reduced lung function and all that, he goes into step 3, where you have to regularly give a low dose inhaled corticosteroid with formoterol. Regularly give it, and as and when the patient has symptoms, he takes additional doses as reliever. There is upper limit to additional doses. You can't keep taking as many additional doses as you want, because otherwise dosage has gone out of the window. But then it gives the upper limit on how many, maybe 8 puffs in a day or whatever. Beyond that, you have to step up, change the treatment. If the asthma symptoms are daily there, or frequent awakening is there with lung function deterioration and recent exacerbation, then you have to go with a medium dose corticosteroid and all that. So many of our patients come with the exacerbation, and such patients, you have to treat the exacerbation. We'll discuss that briefly later. And now once you're done that, you start with a medium dose inhaled corticosteroid formoterol combination. The other side of the arm, I'm not going to discuss much. There you can actually give whatever ICS-LABA combination you want to, and then your reliever can be either a salbutamol or a salbutamol beclomethasone combination. Now again, having said this, we all know what Dr. Judo was saying. Everybody was saying that asthma patients should get inhaled corticosteroid. But then when we look at the field reality in Trivandrum, the study that we did in Trivandrum, you can see that even in a educated population with good doctors in Trivandrum, still about almost half our patients get oral medication, which is a sad reality. Inhalers are costly. Many people do not get free inhalers until we started SHOAS. So people do not use inhalers. They are on oral medication, which is a shame in our country. Again, the COPD patient should be receiving a LAMA or a bronchodilator, but only 6% of them actually receive that as an inhaler. And the asthma patient should be receiving a corticosteroid, but then 30% of them only received a corticosteroid. Remaining 70% did not get the medication that they need. And in fact, COPD should not be getting a corticosteroid, but about 27% of the COPD actually received a corticosteroid. So it's the treatment is suboptimal even in Trivandrum or even in Kerala. So there's a lot that we can do to improve the lot of our asthma patients and the COPD patients as well. The most important thing is the inhaler technique. It's not just the fact that you give an inhaler and patient uses it. Over the years, despite 40 years of inhaler use, what you can see is that inhaler technique hasn't really improved. Still then, and even now, proper use of inhaler remains a challenge for our patients. So study from Trivandrum again showed that in our patients who came to Trivandrum Radiology, only about 20% of them use the inhaler perfectly. About 35%, it's almost maybe adequate. You can say that, okay, not so good, but at least, the drug is maybe working in. But about 45% of patients, almost half of our patients, had very poor inhaler technique. Dr. Jalajamani, who's there in this, Zoom platform, is one of the authors who actually did this study for us. So, important study, which actually was quoted in the meta-analysis which came in the world. Device is also, you have to choose the appropriate device for your patient. And the current guideline, which I read today again suggests that dry powder inhaler may be better because of the environmental safety of the drug. But then they again say that that is not the first priority. The first priority is your patient's choice and patient's ability to use the inhaler. So in Schwarz, we actually went against that. And we have written a meter dose inhaler with a spacer because we felt that our patients best use that device. It's easier to use, hand breath coordination is not required. With a dry powder inhaler, patient has to generate a peak inspiratory flow, which our sicker patients often cannot generate. When your patient on review is not responding to your treatment, the first three questions you ask yourself is, does the patient use the inhaler regularly as advised? Compliance is a major issue, mainly related to cost and the fear of inhalers. So they don't use their inhaler at all, even though they may have one in their hand. The second point is the inhaler technique correct? You have to make the patient sit in front of you and demonstrate. Don't ask them how they use it. Just tell them to bring the inhaler. So in my OP, patients have to come with their inhaler, sit in front of me and demonstrate. They will try to tell you, guys just say, please don't describe the process. You just demonstrate what you do. And that actually will tell us how it is used. Is the device appropriate to the patient and is the dosage adequate? So these are the main questions you ask. And solving these questions will actually take care of most of your patients. The response would be, like I said, patients come on exacerbation. When they come with the exacerbation, the first point for you is to assess the severity. Does the patient have cyanosis? Is there a hypoxia? Does the patient have severe, silent chest, unable to speak? So if there is severity, immediately refer to a center where there's ICU available, where a good care can be given. If those things are not there, you can manage at the primary care or the secondary care level. And the mainstay of treatment is steroids, systemic steroids. And oral prednisolone works equally well as an injected hydrocortisone or injected betnosol. So you don't have to give injections. You just give up oral prednisolone, about 30, 40 milligram would be enough for a normal patient. Bronchodilators have to be given, which has to be given as nebulized. Either a salbutamol may be given or a salbutamol ipratropium combination can be given as a nebulized bronchodilator. Oxygen if the patient has hypoxia, antibiotics if the patient has fever and all that. Purulent sputum is a poor indicator in asthma because the eosinophils in a exacerbation in asthma can produce yellow sputum, so it may be misleading. So always go with fever, X-ray shadows or things like that to start antibiotics, or an upper respiratory infection, which actually indicates that the patient should start antibiotics. If the patient is already on a corticosteroid, inhaled corticosteroid, you can have a short-term step up. So your inhaled corticosteroid dose can be increased to twice the dose, and such a double dose can be taken for 2 weeks and then again brought back to the original dose. So short-term step up of inhaled corticosteroid also can be done. So the last part of my presentation, which we'll cover very fast, is basically to do with what we have done, the Kerala success, which all of you should be proud of because you are all partners in this Kerala success for asthma management. So we started early with the practical approach to lung health program, which was a offshoot of the Stop TB strategy, which had a component called health system strengthening, out of which one was a practical approach to lung health. So we started this long back with the minister and the health secretary and WHO representatives and Government of India representatives actually inaugurating that. We pilot tested in one block. For this program, we actually used a peak flow meter for diagnosis. We used dry powder inhalers and certain other things. It's quite different from what we do in Schwarz today. Studies showed that there was a reduced use of antibiotics and increased patients' satisfaction, but objective measures were not there. And the pilot, which was done in one block in Kollam, could not be carried forward and just collapsed on its own. So we had to move forward. And then when the SDG targets and Ardhram came along, we actually addressed the non-communicable disease part of it with the Schwarz program, which was well supported by our political and administrative leadership, the then health minister and the then health secretary and all. Everybody was extremely supportive of Schwarz. And in Schwarz, we had symptom screening for typical symptoms. We already discussed that today. We have testing with a mini spirometry. We do not insist on a bronchodilator reversibility because post-bronchodilator not done. So that is a limitation of the Schwarz guideline. Initial treatment is with a low-dose inhaled corticosteroid LAMA combination. LABA, sorry, this is wrong. LABA combination, I'm sorry for the mistake. MDI with spacer is the device of choice that we use. We talked of a rapid step down, which is about 2 weeks later if the patient is asymptomatic and step down. Normal step down in the guidelines is after 3 months, but generally in Schwarz, we thought that we could do it faster. at a higher center. If step 5 is needed, patient adding on drugs and all should be done at a higher center. And non-pharmacological management also was covered. Exacerbation management was covered. Patient education, inhaler training, recording and reporting, everything is actually covered in these patients. So somebody is having a good time drawing on my screen. Anyway, so, Schwarz was evaluated and we found that a significant difference could be made in terms of spirometry being done in almost every patient with asthma and COPD, which is a major achievement for our health system. And then we could increase the usage of inhaled corticosteroid almost to 80% in COPD and asthma. And we had, guideline appropriate prescription as compared to those PSCs which are not, doing Schwarz. Of course, a lot of things were put in place, and certain things obviously did not happen as we had expected. So hospital visits we thought would reduce. We thought emergency room visits would reduce. Those did not actually reduce, but the number of patients needing injections and nebulization actually reduced. So certain gains were there. It was slightly hit hard because of COVID, and we still have to recover well from that. Based on our guidelines, many states in India borrowed our guidelines and tried to do their own thing, which included, many states just copy pasted our guidelines. Government of India, the NCD division, came out with its own guidelines, forced by our success in Kerala. And this guideline talks of screening by ASHA workers and all that, and then referring to the district hospital level for a spirometry, we pointed out that numbers are huge and this may not be possible in states like UP and all. So this particular guideline document is now being revised. So the new guideline document should be out soon. So that is also coming from the Government of India side as well. So I'll conclude by saying that asthma is an important cause of mortality and morbidity in India. Diagnostic algorithm and treatment protocols are available. State guidelines, national guidelines, and international guidelines are available. You can follow any of them, adapted to your local. It can be implemented even at primary care level with great success, as we showed in Schwarz. You should all congratulate yourself for that. We should ensure, the theme also says that we should ensure access to proper treatment. We have the advantage in India that our pharma companies give us inhalers at a very cheap rate. You go to any other country, Sri Lanka, Philippines and all, where I went and asked, the inhalers are so costly that they cannot actually give them to their patients. We can actually do it in India. And if we do the treatment properly, we can bring down the mortality significantly. India is one of the countries with the highest mortality due to asthma in the world, and definitely we can bring that down. So thank you for the patient listening, and we'll again come back to the theme, make inhaled treatment accessible for all. We all have a role to play. I'm sure that we will all do our work properly and save the lives of our. Thank you so much for the patience.
Thank you, sir, for the excellent, wonderful presentation, even including the latest GINA update, which was released today morning, I think. And as sir said, it is always a time-consuming process to educate the patients, counsel the patients regarding the use of inhalers, and they train them, then retrain them, and asking them to bring the equipments to the OP, and asking them to demonstrate in front of us. This is very important. The technique of inhalers are very important, even in the pediatric age group. One query from my side is, in pediatrics, we always recommend the inhaler MDI with the spacer. There is no MDI without spacer in pediatrics. But in adults, sometimes we see this usage of MDI without spacer. Is it recommended to use MDI without spacer in adult population? Sir, you are muted.
Sorry. Okay, sorry. So the current guidelines now, the inhaler, which inhaler to use, the choice of inhaler, the most important factor is considered patient choice. Now that is a bit surprising for us, because how does a patient know which inhaler to use? But then that is given importance. The earlier guidelines, the British Thoracic Society guidelines and the GINA guidelines, had charts on what to give. So children above the age of 6 years and adults were clubbed together, and that group you could choose any inhaler, MDI, DPI, or MDI with spacer. Below 6 years, it had to be a MDI with spacer, and very small children, it had to be a MDI with spacer with a face mask. So you're right about younger children, but older children and adults, it is allowed to use that. Now, there are issues with hand-breath coordination. There are issues with inspiratory flow rate. And because of that, in Schwarz, we have forced the government to spend more money and buy a MDI with a spacer for everybody. The spacer also has the added advantage that if you're using steroid, oropharyngeal deposition can be brought down by 80%. So it's not just the ease of using inhaler and better deposition in the lung. It also reduces the oropharyngeal deposition, very important for avoiding hoarseness and avoiding oropharyngeal candidiasis and all that. So I think that is how.
If any other questions, you can just.
I think there are questions on inhaler technique. So the inhaler technique per se varies from device to device. I mean, it'll take a bit of time. We have these videos in Schwas, which probably, we can, if you have a forum that can be shared, you can get it from Dr. Manu and share it so that very clearly even demonstrate how to use it. The main thing is in meter dose inhaler, you need something called hand breath coordination. So the patient has to exhale out fully. The inhalation, the initiation and the inhalation have to be together. And the patient has to take a slow, deep breath inside and then hold breath as much as possible. Then wash mouth if they're using a steroid. So that is a meter dose inhaler. Dry powder inhaler, again, exhale out. Keep the dry powder inhaler device with the broken capsule in the mouth. And then take a deep and fast breath. The speed is very important for a dry powder inhaler. So if the minimum speed is not there, drugs will not reach the lung. And then you take a rapid breath, again, hold the breath as much as possible. Spacer, you can either use as a single breath technique or generally we teach the multi-breath technique where you connect the inhaler to the spacer and breathe in and out of the spacer. And then you can actuate and continue breathing about 5 to 7 times. So that is called the multi-breath technique. And this can be done at tidal respiration. So you don't have to make it very deep and all that. Sufficiently deep inspiration and expiration, and that's how it works. That is in brief. I think details we can cover later. So mini spirometer, somebody has asked a question. So that is a very tricky thing, So mini spirometer, the diagnosis of asthma is based not on the tool. It can be a peak flow meter, can be a full spirometer, but the main diagnosis is based on reversibility, the change after bronchodilate. Our problem with Schwas is that, we thought that would be too much of work for our staff and PHCs. So we did not write a bronchodilator reversibility. That should be there. I think Manu is trying to revise Schwas now. We are more mature with Schwas. So probably that is needed. So the thing to demonstrate in asthma is reversibility. So with a single measurement, either with a mini spirometer or a peak flow meter or a spirometer, you cannot diagnose asthma. So I think that difference has to be. Somebody has written a question that COPD patients should use only bronchodilators and no use for steroid. Is that correct? Yes, it is correct. So as far as possible, if the patient does not have specific indication for the use of corticosteroid in COPD, you are not supposed to use corticosteroid because that can lead to increased pneumonia in patients with COPD. So increased TB, increased pneumonia can occur. So as far as possible, don't give corticosteroids to COPD patients, but there are indications like high eosinophil, repeated exacerbations and all that, where the patient can benefit from corticosteroid. Such people, you can give LABA-LAMA corticosteroid. So first two drugs are either a LABA or a LAMA or a LABA-LAMA combination, and then only the third drug comes as corticosteroid. So if your patient should get, if the patient has to get a corticosteroid, he has to get a LABA, LAMA, and a corticosteroid. If you're just giving a corticosteroid or corticosteroid LABA combination as in asthma, that is not the appropriate therapy. I think there is a question on sputum AFB as well, which is a very important question. So a sputum AFB before spirometry may not be technically very correct. That is a general practice all over India. It's because TB is quite common in our country and we don't want, because spirometry and nebulization are aerosol generating procedures. So if your patient has TB and he goes and does a spirometry, a lot of aerosol will be generated and you will be spreading the TB. So it is always a good idea to rule out TB. But what happens is this often becomes too strict, So if you have a X-ray which is normal, a CT which is normal, just because the patient did not do a sputum AFB, they will not do a spirometry, which is unfair. And I think that has to be taken. I think Dr. Jafar Bashir wants to make a comment. He has raised his hand. Can we open up to him?
Unmute. Good evening, sir. So thank you, sir, for the elaborate and very lucid presentation. And I can confidently say that it cannot get any better than this. So, and I would like to add that actually the theme of this World Asthma Day is making inhaler accessible for all. And the fact is that many years back, Sanjeev sir was a pioneer in developing and implementing Schwas, which made inhaler accessible for all. And was in government service for almost 14 years. And I felt that this SWAS program really revolutionized the treatment of airway diseases in the government sector, and inevitably that for the very common man. But sadly, the SWAS program, as sir mentioned, after COVID has come down. The quality of medicines, the systematic approach, all has come down. So I think my opinion is that the SWAS, the program, has a great contribution for making this theme active for available for all our population. Thank you.
Thank you, Dr. Jafar. I think it's always an issue of money. So government is short of finances, and that has resulted in we have been pushing. Your quality also, you rightly pointed out, after COVID, it's not just our treatment quality of education in schools, a lot of things came down. So Dr. Manu is now restarting the trainings and all. He's starting with Kollam. So we must appreciate the efforts of Dr. Manu and Dr. Kamala also. So Manu introduce all these inhalers into the essential medicine list, and that has resulted in the government now. Any of you can intend and actually purchase if you have money. So that is, money is always a problem, but at least we have put that on the list. I think somebody has repeatedly asked about Montelukast. That's the last question. So Montelukast and Derifilin, I think I can take both of them. Montelukast, Derifilin and all. In the previous 2024 guidelines, it was there at the bottom of that, treatment algorithm, which I showed. They felt that keeping it there actually will impede patients from getting the right inhalers. So they actually downgraded that recommendation now. So Montelukast as an added treatment, it may be beneficial for patients. Derifilin as an added treatment may be beneficial for patients, but those should not be the primary treatment. So my colleagues in the private sector, for example, KIMS Hospital, Trivandrum, they very proudly say that I have not written a single Derifilin for any patient for the last 15 years and all. But me sitting in the government hospital, even today, I have written Derifilin to my patient because they insist and ask for it, and that is a free medication which is readily available. So you cannot, deny something to your patients when it's there in the hospital. I do it with a heavy heart. International guidelines say that it should not be given the way we give it. But then there are studies from China and India which show that unlike Western countries, maybe our patients metabolize their film better. So we really don't know because side effects, as mentioned in Western guidelines, are not there to that particular extent. So I think, I agree with you. For severe COPD in SWAS, we have written triple combination, LABA-LAMA ICS, which was the previous guideline. So we didn't go with the LABA-LAMA combination. The LABA-LAMA combination per se would cost as much as a 3-month course of tiotropium. So we looked at the economics of it also. So if you actually need tiotropium, lasts for 3 months, and if you give a LABA-LAMA, the cost for the government for each patient will go up 3 to 4 times, or even more if you use some of the newer combinations. So Indian guidelines for COPD are being rewritten now, PGI Chandigarh. So they are also discussion. They did a lot of meta-analysis, and they feel that LAMA alone may be equally good as LABA-LAMA. Only the small difference between LABA-LAMA and LAMA may not justify so much of additional cost to the government. So that is a debatable issue. I agree with the point that you're making, but then, that is how we wrote. We are going to revise it. Maybe, we'll look at it again on whether it can be done. Management of asthma and COPD more or less for exacerbation, I agree that it looks more or less similar because for a COPD exacerbation also, you're supposed to give oral corticosteroid. You're supposed to give the bronchodilator. And of course, but for COPD, you don't continue the inhaled corticosteroid just because they had exacerbation. You give the inhaled corticosteroids. But in asthma, after the exacerbations, I think we covered all the questions.
Okay, thank you, sir. There are no other questions. I think we can conclude the session, and I invite Preetha Madam for the final remarks and vote of thanks.
Praveen Kekau.
Yeah.
വേൾഡ് ആസ്മ ഡേയുടെ അന്ന് ശരിക്കും സാറിനെ സ്പീക്കറായിട്ട് കിട്ടിയതൊരു വലിയ ഭാഗ്യമായിട്ട് തന്നെ കരുതുകയാണ്. എല്ലാ മാസവും ഏതൊക്കെ ഡേ എന്നുള്ളത് കലണ്ടർ എടുത്ത് നോക്കും. അങ്ങനെ മെയ് മാസം നോക്കിയപ്പോഴത്തേനും ആദ്യം ആസ്മ ഡേ ആണ് കണ്ടത്. പിന്നെ ഡെങ്കു ഡേ, തലസീമിയ ഡേ ഇങ്ങനെയൊക്കെ വരുന്നുണ്ട്. അപ്പം ഞാൻ സാറിന്റെ കാര്യം ഓർത്തു. പക്ഷെ കഴിഞ്ഞ മാസം സാറിനെ ബുദ്ധിമുട്ടിച്ചതേ ഉള്ളൂ വേൾഡ് TB ഡേക്ക്. അതുകൊണ്ട് എനിക്ക് ചോദിക്കാനൊരു പേടിയായിരുന്നു. പക്ഷേ സർപ്രൈസിംഗ്ലി കഴിഞ്ഞ ആഴ്ച സാറ് ഇങ്ങോട്ട് തന്നെ പറയുമായിരുന്നു, ഇങ്ങനെ PCCMന്റെ ഒരു ഇതുണ്ട്, അപ്പൊ KGMOA കൊണ്ട് പങ്കെടുപ്പിക്കാവുന്ന. ശരിക്കും സാറിന്റെ ആ വിശാല മനസ്കതയ്ക്ക് മുമ്പ് ആദ്യം തന്നെ നന്ദി പറയട്ടെ. നമ്മളെ ഓർത്തതിന്, KGMOA ഓർത്തതിന് ഒത്തിരി പേർക്ക് ബെനിഫിറ്റ് ചെയ്തെന്ന് ഞാൻ വിചാരിക്കുന്നു. കാരണം ആസ്മയെ കുറിച്ച് ഇനി ഇതിൽ കൂടുതലൊന്നും പറയാനില്ല. സാർ എല്ലാ ഇതും കവർ ചെയ്തിട്ടുണ്ടായിരുന്നു. വൺസ് അഗൈൻ സാർ, ഞങ്ങളെ ഓർത്തതിനും ഇതിൽ ഇൻക്ലൂഡ് ചെയ്തതിനും വലിയ KGMOA ഫ്രറ്റേണിറ്റി, ഹോൾ ഓഫ് KGMOA ഫ്രറ്റേണിറ്റിയുടെ കണക്കായിട്ടൊരു താങ്ക്സ് ആദ്യം തന്നെ പറയുന്നു. പിന്നെ ഇതിൽ സ്റ്റേറ്റിനെ റെപ്രസെന്റ് ചെയ്ത് വന്ന ഡോക്ടർ ശ്രീകാന്തിന്, അതുപോലെ തന്നെ നമ്മുടെ അക്കാഡമിക് സെൽ ചെയർമാൻ ഡോക്ടർ വിപിൻ വർക്കി, അതുപോലെ നമുക്ക് സ്വാഗതം അർപ്പിച്ച ഡോക്ടർ പ്രവീൺ, ഡോക്ടർ മിനു കൃഷ്ണൻ, ഡോക്ടർ അഭിലാഷ്, പിന്നെ കോട്ടയം KGMOA സെക്രട്ടറി ഡോക്ടർ ആഷിഖ്, അതുപോലെ APCCM സെക്രട്ടറി ഡോക്ടർ ജൂഡോ സാറ് മെസ്സേജ് തന്നു. അത് എല്ലാവർക്കും, അതുപോലെ APCCM മെമ്പേഴ്സിനും, എല്ലാ KGMOA, എല്ലാ ഡിസ്ട്രിക്റ്റിൽ നിന്നും പങ്കെടുത്ത KGMOA മെമ്പേഴ്സിനും ഒറ്റ വാക്കിൽ നന്ദി പറയുന്നു. താങ്ക് യു.
Thank you. Good night.
Thank you once again, sir and madam, and thanks all for attending. We will conclude the session. Good night. Bye.